one of the most important international webinar tonight. We have three guest speakers tonight, and the chair of this session are Prof. Assam Manna and Dr. Adil Ibrahim. All of yours, Prof. Assam. Thank you very much.
Thank you so much. Good evening, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Wa salatu wa salam ala ashraf al-mursaleen, Sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. I think, but I'm sure that all the attendees and the panelists, they agree with me that science everywhere, and you can get science from books, from any materials, but experience is not everywhere. Experience is very seldom and very rare and very crucial. And one of the target of our mega online course is to get experience and to bring experience for everybody all over the world. And it proves this webinar. It is one of the best webinars in the field of anesthesia, intensive care, and pain management. And now we are followed by everybody all over the world, from the Far East, from Middle East, from Latin America, from Europe, from USA. And today we have very distinguished and eminent speakers. And as usual, and Professor Samir Ansary is a star and the icon of our mega online course. He will introduce his series about the nutrition in the intensive care. And the second speaker will be Dr. Hazim Yassin from Saudi Arabia. And the last speaker will be Professor Barbara Rogers from Ohio, USA. And this proves what just I said, that we are bringing all the experience, most of the experience. Now we have experience from the Egypt, from Saudi Arabia, and from America. And we provide all of this experience and science to the attendees on a golden plate. So I appreciate the presence of our distinguished speakers, and we will speak today, as we said, about intensive care and anesthesia. And it is a great honor for me. He will share with me in introducing the speakers, Professor Adil Ibrahim. Let us start with our eminent and distinguished speaker, Professor Samir Ansary, with his series about the nutrition in the ICU. So please, Professor Samir Ansary, go ahead, and the floor is yours, sir.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Assam, for this nice introduction and nice words. Good evening, my dear colleagues. Good evening, our attendees. Today, we are going to, in continuation for our series of nutritional support in the ICU. We will continue today with and start with TPN calculations. Continue my series of nutrition support. I will speak today about total parenteral nutrition, and I will concentrate today on the formula calculation, how to calculate the formula for nutritional support or for TPN. As we know, at start, you have to evaluate your patient. You have to assess your patient. As we said before, you have to know the lab results first, how much he will need from carbohydrates, how much he will need from proteins, from lipids. Suppose the patient suffering from high triglycerides, you have to go down with lipid support. You have to assess your patient. After that, you will decide if you will start with total parental nutrition support or with partial nutritional support. As you know, as most of you know, there are two types of parental nutrition. Peripheral nutritional support through peripheral vein, if the central vein is difficult for you, and the total parental nutrition support. In peripheral support, we give some enteral nutrition and just supplementation with additional parenteral nutrition through peripheral vein. But we have to decrease the osmolarity of the infusion calories. We have at least 100, 900. If the osmolarity is high, you can't infuse through a peripheral vein. And so the peripheral parental nutrition is a temporary support or a temporary bridge till you achieve a full enteral nutritional support. Routes of administrations, and so if we speak about peripheral parental nutrition, it is a short-term use only, not for a long time, just a temporary support, as I said, and the osmolarity is low. Dilute solutions, low osmolarity. Formula osmolarity is less than 900 or 600. Fluid restriction is not necessary because in peripheral nutrition support, you have to give a large volume of solutions to decrease the osmolarity of the nutritional formula. For TPN, we, of course, select a central axis. Central axis may be through the subclavian vein, internal jugular vein, or femoral vein, or through peripheral central cannulations or PEC line, or through the cubital veins. Total parental nutrition must be individualized for the patient. There are standard concentrations of protein, carbohydrate, and fats available, standard volume. As we have before, the 10% glucose, 50% glucose, 70%, also lipids 20%, 10%. Protein, amino acid concentrations 10%, 15%. These are standard concentrations available in most of the hospitals in which there is no lab for nutritional support preparation. Most of the world have a lab, nutritional lab, for preparing the formula or for modulating the formula according to the patient needs. And I think it varies from patient to patient. And so we have to prescribe the ingredients which are suitable for every patient. And of course, it differs from patient to patient. But in the market, there are solutions ready or formula ready, which contains the 3 macronutrients together, carbohydrates, protein, and fats together in one bag. And the others contains two ingredients, carbohydrates and protein, and the fats could be separated, infused in separate solutions. And so the standard concentration which we used before is limiting the degree of individualization using these standard solutions. And so better to have a nutritional lab in your hospital to formulate according to patient's need how much carbohydrate, how much proteins, how much lipids. However, mixing different formula in calculated amount can be used to develop the feeding solutions for most patients. And as we see here is pictures of 3-in-1 solutions as KBVN, and I think most of the hospitals are using it. It contains protein, carbohydrates, and fat together, and we can mixing the bridge in between it and infusing through a central line. These are examples of already prepared solutions for infusion for TPN. We have to ask ourselves, what is the patient energy? How much calories this patient requires? And I think we discussed this one in the previous lectures. We have 3 methods, as we know. The most accurate one, which depends on indirect calorimetry, which depends on carbon dioxide production, how much, and oxygen consumption, how much, and you can get these 2 items from the ventilator, and so used for patient on ventilator. And this mostly is the most accurate one for calculation the calories which we enumerated last time or last lecture. And the standard one or the routinely used one, which is the roughly one or standard one, about 25 to 30, 35 kilocalorie per kg per day for the patient, and we can increase if the patient in passing or staying in a severe catabolic state. After that, you have, after calculating the calorie requirement of your patient, you have to calculate also the fluid needs per day, how much fluid, and there are several methods, as we said. First, 10 kilo, about 100 cc per kg. Second, 10 kilogram, 50 cc per kg, and over that 20 cc if the patient age less than 50 years. Also, don't forget, in addition to the macronutrient which you add to TPN, which is dextrose, amino acid, and the lipids, the electrolytes, sodium, chloride, magnesium, potassium, phosphate, and calcium. And this is very important, in addition to trace elements. And I think today I will not speak about trace elements. I am going to speak about trace elements in a separate lectures, mostly next week. This is an example of two-in-one solutions. They can use dextrose, macronutrient, dextrose, and amino acid here, in addition to other bag containing the lipids. And you have to decide how much vitamins you need, how much minerals you can use, and according to patient situation. How to write TPN? There are several steps, and we must be oriented with that. Identify the energy needs, as I said, calorie, how much calories you need, and then the first step, distribute this energy. Suppose you have 2,000 calories, and you have to distribute to the 3 macronutrients: carbohydrate, protein, lipids, and so on, according to percentage which you select. We mostly use 60 to 65 for carbohydrates, 30% for lipids, and the remaining for proteins. And suppose that your patient is in severe catabolic state, you have to add proteins and decrease the other ingredients. And so this is a formulated or modulated formula according to patient needs. After you calculate the energy, and after distributing it, you have to convert the energy to grams. You have to change the energy to gram. And after that, convert the gram to solutions. And so the first step, calculation the calorie. After that, distribute the calorie to the 3 macronutrients you have. And then it changes the calories to grams, and it changes the gram to solutions or volume. 3 steps you can write through it. You can write your formula. Macronutrient distributions, simply we use this formula. Protein 10 to 35%, according, suppose patient with extensive burn, you have to increase your percentage of protein, multiple trauma or extensive trauma, and so on, catabolic state or the early state after trauma, or even in the anabolic state, which is the third state, which I said about it or speak about it in the last lectures. Fat from 20 to 35%, carbohydrate from 45 to 65%. And then add your electrolyte requirement, vitamins, trace element, and the minerals and the medications. And as we know, most of you know, trace element estimation, mostly we use roughly estimations, not depending on the lab estimations. But you can suspect it from certain equations and from certain enzyme estimations and some functional assay. And I will speak about it in detail next week. Energy kilocalorie distributions, how? Suppose these are examples of how to formulate your calories or how to write your formula of TPN. Suppose your patients needing 2,000 calories per day. Substrate distributions, protein I will give 20%, for example, and so I will give him 400 calories. Carbohydrate 50%, I will give 1,000 calories. Fats 30%, I will give him 600 kilocalories. Then I change this calorie requirement into grams. Protein, I will divide 400 kilocalorie protein by 4, will give me 100 grams. Divide it by 3.4 will give me 294 grams of carbohydrate or 300 grams of carbohydrate. Every gram of carbohydrate in TPN give me 3.4 calories. Fat I will divide by 10 will give me 60 grams of fats or lipids. And after that, I change this gram to volume, to solutions. Protein, suppose proteins you will need 100 grams, it will be available in 1,000 ml of 10% amino acid. Every 100 ml of amino acid, 10% contain 10 grams, and so the 1,000 to contain 100 grams. Carbohydrate also, suppose you have solutions of 50% 50% dextrose. This meaning 1 liter of your 50% containing 500 grams of dextrose, and so you will use 300 grams. Fats, every 1 liter of 20%, of course, will contain 200 grams of fats, and so the 50 grams will be available in 250 ml. This in case of you have a fixed or standard concentrations of TPN solutions in your hospital. But suppose you don't have these solutions, or on the other hand, you have a nutritional lab on your pharmacy, you just write, I need how much calorie from every macronutrient and send it to the lab. Or you can summarize it or change it to percentage. I need how much percentage from lipids, how much I need, for example, 2,000 cc of TPN containing 40% protein, containing 50% carbohydrate, and we modulate it according to our patients, and I will give example for this. Calculating the osmolarity of parental nutrition solutions to be sure it is not high. And I want to say something. This is not meaning you infuse through a central vein, there is no complications. Thrombotic complications encountered, and we see it even with 5% glucose for long period of time through the peripheral vein. Also, the central vein, subclavian, internal jugular, and you must be oriented all the time and suspect these complications. If you use high percentage of carbohydrates, 70%, 50% for a long time, suspect you will see some complications as thrombophlebitis in this vein, and we see many patients with thrombotic complications in the subclavian, and the swelling and redness and inflammation in the upper half and obstruction and so on. And so you must be aware of this complication, but you have to calculate the osmolarity of parental nutrition before using. And this is a simple equation for calculating the osmolarity. How many grams of dextrose multiply by 5? How many grams of protein multiply by 10 and multiply the lipids by 1.5? 5 for carbohydrate for dextrose, 10 for protein, and 1.5 for lipid. This and the summation of this number give you the osmolarity of your solution. Dextrose 5 and protein 10 and lipids 1.5. This is an example of automix, and there is automix for lab for nutritional lab in the pharmacy inside the hospitals, and prepared from a large volume of concentrated solutions according to order you send or according to the nutritional sheet you send to the pharmacy. Macronutrient concentration percentage, which is grams of solute per 100 ml of fluid. I give you some examples how to calculate. Suppose you have dextrose 70%. This meaning every 1,000, every 100 contain 70 grams every 100 ml, and the 1 liter will contain 700 grams. If you times by 3.4, give you the total calories in the 1 liter of the 70. 10% amino acid solutions contain 10 grams per 100 ml and 100 grams every 1,000. 20% lipids contains 200 grams every 1 liter. Sample for dextrose calculation, 1,000 ml of D50 will contain 500 grams of dextrose. 100 kilocalorie by multiplying 500 gram dextrose by 3.4 kilocalorie per kg. TPN, carbohydrate, every gram give me 3.5 kilocalorie per kg. For lipid calculations, lipids, if 10% solution, every cc will give you 1.1 kilocalorie. In 20% solution, and I think this is the most one used and we prefer it for containing essential amino acids, every cc containing 2 calories per ml and 20% lipid. Calculation of dextrose amino acid with BG-backed lipids. In this method, we use mixtures of carbohydrate and protein, and in addition, another bag containing the lipid emulsions or lipid solutions to be infused. Examples for calculations. I will give example here for calculations of 2N1. 2 macronutrient, carbohydrate and protein in one bag, and the lipid in a separate bag. Suppose my patient need 1,800 calories and protein 88 grams and fluid 2,000 cc. I will subtract first the fat content to be put in a separate bag because I will use 2 bags. One bag containing carbohydrate and protein, and the other bag, second bag, will contain lipid. And so I calculate the lipid, 1,800 kilocalorie times, I suppose I want to give 30% of calorie as fat. I will get 540 kilocalorie as lipid. We can use it for, we can use 10% solution or 20% solution. If I use 10% solutions, I will divide 540 kilocalorie by 1.1, every cc containing 1.1 kilocalorie. And so will give me 491 cc for 24 hours. The divided it by 24 hours, it will give me 20 cc per hour infusion of 10% lipid. And so I calculate how much calories I need from lipids and separated it from the total solutions, extracted it from the total solutions, and put it in a separate bag and infused it over 24 hours or over 12 hours according to time. We prefer always lipids to be infused over long period of time to avoid the rapid increase in triglycerides and lipids and so on in the blood. Mostly we infuse over 12 hours. If you infuse over 12 hours, you will divide by 12 hours. It will give you about 40 cc per hour of 10% lipid. After that, this is the volume of lipid in the second bag. I extract it from the total fluid the patient will receive, the 2,000 cc minus 491 for lipids. The remaining fluid, 1,509, will be in the first bag, which will be distributed to both carbohydrate and protein. Protein calculation, after that, suppose the patients need 88 grams of protein. I will do, according to body weight, protein calculation, suppose I selected 88 gram protein for these patients. I divide by the total volume for the first bag, which 1,509, and multiply by 100. I will get the percentage of protein or amino acid solution. After that, I calculate how much calorie from protein I give. I give 88 gram protein times 4 calorie for every gram. I will get 352 kilocalories. And so I have to extract from the total calories which the patient need 1,800 minus 540 for lipids and 352 for protein. The remaining will be 908 kilocalories. These for carbohydrates. And so, as we see, we change we calculate the calories first for fats and extract it from the total calories and then distribute the total calories, remaining calories, to protein and carbohydrates. For the remaining calorie for carbohydrate, 908 calorie divided by 3.4 kilocalorie per kg will give me how much gram dextrose will be given to this patient. 267 gram dextrose divided by the remaining volume 1,509 multiplied by 100 will give me the percentage of dextrose solution which I have to order for this patient. And so I ordered 17% dextrose for this patient. Rate of amino acid dextrose infusion divided the total volume of this protein and carbohydrate by 24 hours will give me 63 cc per hour. Suppose I want to give the 3 macronutrients in one bag. It is very simple, like more simple than the previous one. Suppose I need 1,000 total calories, 1,800, protein 88 grams, and the fluid 2,000 cc. I have to calculate lipid or calculate lipid first. 30% lipid will equal 540. 540, if I give 10% solutions, will divided by 10 kilocalorie to gain how much gram of fats I will give, and then divided by the volume of solution and multiplied by 100, giving me the percentage of lipids which I have to order in my sheet, 2.7%. It is a mathematical method to calculate how much percentage for every macronutrient you have to give to the lab to prepare you in the nutritional lab. Protein 88 gram divided by the total solution or total fluid 2000 and multiplied by 100 will give you 4.4% of amino acid. Timing by 4 to get how much calorie of protein equals 352. After that, dextrose will be the remaining one will be 900. 900 divided by 3.4 kilocalorie per gram give you how much gram dextrose you will give, and the percentage will be 13.4% of dextrose solution. And so, as we see, there are many methods of ordering the calorie requirements for TPN to your patient. If you have standard solutions, as we said, you have to calculate the calorie and you change this calorie to gram and then change the gram requirement to volume in your standard solution. If you have lab in your hospital, you have to calculate the percentage for every macronutrient you are going to infuse to your patient. And so, suppose I have 100 gram protein, how much it represents to the total volume, how much percentage, and I need percentage, 20% carbohydrates, 10% and so on. Infusion rate, the rate of amino acid dextrose lipid infusion, total volume by 24 hours will be 83 cc per hour. Additional sterile water to standard total parenteral nutrition. We have, suppose your formula calculated in 1,800, and the fluid requirement for your patient is 2,400 or 2,500. You have to give the difference as water or fresh water or as IV normal saline. Fluid needs, suppose the fluid needs 2,450, exceeding the nutritional formula, you have to give the difference as sterile water or as needed. This is an example of nutritional standard sheet for nutrition support, which you order or which you send to the pharmacy for preparing your solutions. You have to be sure from the name of the patient and administration and route of administration. In either enteral nutrition or TPN, you have to write this sheet. You have to write all the electrolytes which you need. Also dextrose, how much amino acids, how much lipid, how much. Even you write in grams or you write in percentage, as we explained now. Also, you have to add the vitamins and the trace element, and if you need insulin, if the patient is diabetic, trace element you have to write. Suppose you want to add some drugs as H2 antagonist or proton blockers, you can add here, and you have to write the rate, how much ml per hour, and the volume, total volume, how much, and which method you will give, continuous infusion or cyclic infusion. You have to mention this in your sheet. Of course, when you write nutritional sheet, you have to monitor your patient as a feedback monitoring for any complications could be happen from TPN nutritional support. Initiation of TPN always start slowly and also stop slowly. This is a rule. To avoid, start slowly to avoid the refeeding syndrome, which will occur mostly in cachectic patients or malnourished patients, severely malnourished patients. If you push nutrition support, even with enteral nutrition, if you push the nutritional support very fast, you will get refeeding syndrome complications, which is manifested by hypokalemia, severe hypokalemia, and hypophosphatemia, which predisposes to severe arrhythmia up to arrest. If central access is not available, peripheral parenteral nutrition should be considered, as I said at the beginning. As protein associated with few metabolic side effects, maximum amount of protein can be given on the first day, up to 60, 70 grams of protein per liter. We can give them protein, no problem. You can give rapidly, or the maximum amount can be given in the first day. Maximum carbohydrate given the first day is 150, 200 grams per day, or 15 to 20% final dextrose concentration. Don't use high concentration in first, second day. Always we proceed over gradually up over 2, 3 days, 4 days to avoid refeeding syndrome and other complications. Dextrose content of parenteral nutrition can be increased if capillary blood glucose level are consistent with than 180 mg%. Intravenous fat emulsions in parenteral nutrition in general can be increased if triglycerides are less than 400 mg%. And we have to follow really the triglycerides in the first week, even daily or twice per week, to be sure the patient not suffering from hypertriglyceridemia. Fluid needs, sorry. Fluid needs, as I told, if the patient need more fluid than the parenteral formula fluid content, you have to add the difference to compensate for this. Transition to enteral feeding in pediatric and in adult also in general. Try to taper more slowly. Don't stop the TPN suddenly. Otherwise, your patient will suffering from rebound hypoglycemia. And specifically in infants or pediatric, we have to avoid this complication. Generally, parenteral nutrition is continued till 70 to 80% of energy needs are met enterally. When you shift from total or enteral from TPN to enteral nutrition, you have to be gradual withdrawing the TPN solutions, not all of a sudden, and be sure your patient is taking adequate enteral nutrition, about 70 to 80%. Rebound hypoglycemia, if you stopped it, and sometimes we stop it and add 10% dextrose to be sure the patient will not suffering from rebound hypoglycemia. If adults receiving oral or enteral nutrition sufficient to maintain blood glucose, no need to taper TPN. Medications could be used with TPN. Yes, some medications could be added, like insulin, like selenium, zinc chloride, ranitidine, heparin, octreotide. Some drugs, metoclopramide, could be added to the TPN, but avoid injection only through the route of injection or through the route of supplementation of the drugs, not the line, not the pathway of the nutrition, because the infection rate is very high really. And so we always try to keep the IV infusion as a separate line for TPN solutions, not manipulated. Infusion schedules may be continuous parental nutrition. We give over 24 hours to avoid the nursing interruption and the patient will be tolerated more adequately and the nursing time will be spared. And even touch contamination is less if you give as a continuous parenteral nutrition. But sometimes, but of course, it has its disadvantages. It may lead to patient persistent anabolic state and increase the lipid storage by liver and reduce mobility in ambulatory patients and the change or altered insulin glucagon ratio. And so mostly we prefer cyclic PM, usually over a period of 12 to 18 hours. Its advantages approximate normal physiology of intermittent feeding. The patient of us, there is intermittent feeding, ideal for ambulatory patients and allow normal activity and improve quality of life. Cyclic PN advantages maintain a nitrogen balance, more positive balance actually, and more visceral proteins and more better than continuous. These advantages not tolerated by critically ill patients require more nursing manipulation, increased potential for touch contamination, increased nursing time. Monitoring for every nutrition support, suppose even enteral nutrition or parental nutrition, you have to monitor your patients routinely with at least 3 times per week and at the beginning of admission to ICU. Also signs and symptoms of edema daily, you have to estimate and write it in nutritional sheet. Signs and symptoms of dehydration through central lines, through IVC, through purge variability, many methods for estimation the volume state. Also fluid intake, output daily, very important, and adequacy of intake at least 2 times per week. And the nitrogen balance, nitrogen intake, nitrogen output difference is very important for estimating your patient. And always suspect if your patient exhibiting positive nitrogen balance through these estimations, these are prognostically very important and give you good prognostic signs that patients will be more better and more survive. Protein markers, which we depend on at serum albumin, it is really mostly a prognostically marker because of long half time, maybe 21 days or more. In mild malnutrition, it will be from 3.5, dropped to 2.5 to 3 in moderate malnutrition. Severe malnutrition is less than 2.5, and actually it is a prognostic marker rather than for follow-up of nutritional support. Other protein markers which has a short half-life as pre-albumin, 2-3 days of life, preferred for monitoring. Transferrin also 8-9 days. Retinol binding protein and somatomidine about 12 hours, 8 hours, and so this is better for as protein markers for monitoring. Nitrogen balance is very simple, really. You can calculate the nitrogen intake minus the nitrogen output, and as you know, gram nitrogen equal 6.5 gram of protein. And so you calculate how much protein this patient take all over the 24 hours and how much urine output is excreted, and calculate the nitrogen balance difference will give you if your patient is on nitrogen positive or negative nitrogen balance. Serum electrolyte, blood urea, nitrogen, creatinine, 2-3 times per week. Serum glucose, calcium, magnesium, phosphorus, weekly or as ordered. Phosphorus is really very important, especially at start or restart of feeding to avoid refeeding syndrome because it's very dangerous to drop. And even if you find your phosphorus level, serum phosphorus is low, you have to more be gradual with initiating your feeding and may waiting for feeding support till you correct phosphate level. Serum triglycerides, baseline serum triglycerides and weekly thereafter, and take care of other solutions which you infuse as sedative as propofol. You have to calculate its volume and add it to the TPM formula. You consider it in your caloric requirement for your patient. Also, the respiratory quotient, very important to follow it if you have indirect calorimetry in patient. And our target, as I said before, the optimum range from 0.8 to 0.9. If it is more one, either you overfeed your patient and you have to decrease your total calorie, or you decrease the carbohydrate content. If your patient exhibiting a respiratory quotient 0.7 to 0.8, this meaning fat and protein oxidations depending more than carbohydrates. And I think, and of course, I have to say something about the complications of TPM. You can suspect many complications, from starting of inserting your central line, the mechanical problems, pneumothorax, bleeding, infection, and so on, hyperosmolarity and electrolyte disturbance, hypokalemia, hyperkalemia, all complications you can suspect and you have to avoid, and especially if carbohydrate excess and cholestasis, and these lead to problems in the liver. And so also we have to see and follow up the lipid profile. If you find your liver function test is increasing, this meaning you have to go down with carbohydrate, especially after the first week, second week, you may face a problem of cholestasis, and this is inside the liver, and so you have to go down with carbohydrate. Next week, inshallah, I will concentrate on trace elements. Thanks for you. Good luck.
Thank you, Prof. Ansary, for this very informative lecture. I think, as I said before, science everywhere in the books, but you will not find this experience except in our webinar in a mega online course, and from expert person like Professor Ansary. And I think this type of calculation of the nutrition, or the nutrition as an item as itself in the ICU, it needs to be considered as one of the subspecialty itself, because it needs a lot of experience. It needs patients from the doctors also who are monitoring. The patient should be monitored, and the patient is chronically present in the ICU. It needs a lot of investigations, and it is not like something simple. It is an art, and a big art in the ICU. So we appreciate the lecture from and this information from our legend, Professor Ansary. And now I think any questions will be at the end of the lectures.